with the theme established by Dr. Chawla, and that is the spectrum of cardiometabolic disease. But I want to add another therapeutic option that's perhaps complementary to the interventions that he discussed. But this progressive chronic disease begins with insulin resistance in utero, as discussed by Dr. Shishaya, then progresses to clinically identifiable states of high risk, prediabetes, metabolic syndrome. You could add gestational diabetes to that, and then on to type 2 diabetes or cardiovascular disease, or both in single individuals. Obesity exacerbates insulin resistance and impels this disease progression. And what I'd like to talk about today is the role of kind of more modern approaches to obesity medicine, the tools of weight loss therapy in both preventing diabetes, and which we're going to need to do to stem this epidemic, and as we've discussed throughout this meeting, optimal treatment of type 2 diabetes, looking at our three principal modalities: lifestyle intervention, medications, and bariatric surgery. Of course, we're all aware of the diabetes prevention program. We see here cumulative incidence of diabetes over 4 years, highest in the placebo group. The lifestyle intervention here decreased progression to diabetes by 58%. Metformin was less effective, intermediate between placebo and lifestyle. But what about the dose-responsive weight loss and the prevention of diabetes? Here, reading from kind of right to left, we see progressive weight decrease from baseline. Once you get to about 10 kilograms of weight loss here, which is about 10% of weight loss, you've really prevented all the diabetes you're going to prevent. The same is true with medicine-assisted weight loss. Here's a phase 3 clinical trial with phentermine topiramate over 2 years. Lifestyle modification plus placebo is the top graph. 2 doses of medications on the bottom led to about a 10% weight loss sustained over these 2 years compared to the 2% weight loss with lifestyle alone. And here's the cumulative incidence of diabetes in that study in those individuals with metabolic syndrome or prediabetes at baseline. You can see the lifestyle modification had the highest cumulative incidence, rising progressively over 2 years. But either one of these doses of this medication really dropped that down to very few cases of diabetes developing. And this amounted to a 79% reduction in diabetes over this 2-year period. Again, looking at this dose response with progressive weight loss category versus the annualized diabetes incident rate, once you get to 10% weight loss, you've again prevented the diabetes you're going to prevent. You could lose more weight loss, 15%, but you don't prevent any more diabetes. Here's another diabetes prevention study with high-dose liraglutide, 3 milligrams a day, in patients with impaired glucose tolerance at baseline. You can see at the top, the blue curve is placebo lifestyle alone, and the treatment with the drug is the red curve. Again, an 80% reduction in progression to diabetes over this 3-year period now. And this was accompanied by decreased glucose values and decreased insulin values on the lower graphs. You could lose more weight with bariatric surgery. This is kind of a nested case control study in the UK. Patients with equal degrees of adiposity in blue that did not opt for surgery versus patients that did have bariatric surgery over a 7-year period. Again, an 80% decrease in progression to diabetes. It's like about 20% of patients with metabolic syndrome prediabetes are predestined to get diabetes independent of weight loss. But we can prevent 80% of progression to diabetes with this 10% weight loss kind of maximal threshold that I've been referring to. And if you look at the ACE algorithm, diabetes algorithm for prediabetes, you see across this top that yellow bar, lifestyle therapy, including medicine-assisted weight loss, appropriate for treating the hypertension and dyslipidemia, as well as the dysglycemia. If lifestyle therapy and medicine-assisted weight loss doesn't get you where you want to go in terms of glucose values, you can consider metformin or a carbose, and perhaps when more aggressive intervention is needed, perhaps a TZD or GLP-1 receptor agonist. But if you achieve 10% weight loss in these patients, that's going to get it done for the majority of patients. But we have a problem, and that is the high prevalence of these patients at risk. This is a study from Chandigarh, kind of a scientific sample, community survey, showing prevalence rates of metabolic syndrome using the modified ATP3 criteria, overall prevalence of 45%, higher in women at 50%, compared to men 39%. So how can we engineer structured weight loss interventions, or perhaps medicine-assisted weight loss, for an at-risk state that encompasses 50% of the population? The important thing here is, I think, is risk stratification. Not all these patients are the same in terms of their diabetes risk. We developed an approach called cardiometabolic disease staging, using discrete data from a number of epidemiological studies, and created several stages here of risk. Zero are no risk factors, no metabolic syndrome risk factors, is kind of sometimes referred to as the metabolically healthy obese. Patients with 1 or 2 metabolic syndrome risk factors. Stage 2 is metabolic syndrome or prediabetes, but not both. And stage 3 is you meet criteria for both metabolic syndrome and prediabetes. So very simple, using quantitative data readily available to the clinician. We validated this risk staging strategy in a number of national cohorts from the United States. This is the CARDIA study. So you can see cumulative incidence of diabetes over 12 years. Those stage 0 metabolically healthy obese in blue, no metabolic syndrome traits, did not develop very much diabetes at all. All these patients, by the way, had overweight or obesity as well. Then 1 or 2 metabolic syndrome traits in red, higher cumulative incidence, metabolic syndrome or prediabetes, stage 2 in light blue, or in black, meeting both criteria. This simple approach, again using quantitative data available to the clinician, can predict, stratify risk over 40-fold in these patients with metabolic syndrome, or in these patients with overweight or obesity. We've created kind of weighted these different risk factors and engaged in continuous analysis and developed more sophisticated equations, and that's applied here to phase 3 clinical trial data from the phentermine topiramate phase 3 clinical trials to really see if prevention of diabetes varied as a function of baseline risk. So this was a weight loss study, obviously, and this is a diabetes rate. In the blue curves on the bottom, these are patients in low-risk strata. The dotted curve is a placebo lifestyle. The solid curve is lifestyle plus drug. And you can see there's very low rates of diabetes in these low-risk strata, and you're not preventing large numbers of diabetes through this intervention in this low-risk strata. On the other hand, the orange curves correspond to the high-risk strata at baseline. So placebo is the dotted curve, drug is the solid curve. Here we're preventing a lot more diabetes, a lot more effectively when we engage in this weight loss intervention in patients with high risk at baseline. If you look at numbers needed to treat to prevent 1 case of diabetes, in the high risk strata it's 18, in the low risk strata is 258. So your healthcare system, or your national government, or your clinic, if you wanted to engage in diabetes prevention and do it with higher benefit-risk ratio and cost effectiveness, you could employ a risk stratification strategy such as this to bring more aggressive therapies to those at highest risk. So transitioning to type 2 diabetes therapy now. So here's a question for you. What if there was a treatment for diabetes that reduced hemoglobin A1C by 0.5 to 1.6%, while other conventional diabetes medications were reduced in dosage or eliminated, led to a 7 to 10% decrease in body weight, reduced blood pressure, improved lipids, was renal protective, improved sleep apnea. 87% of patients with diabetes and obesity in the Sleep Ahead study had sleep apnea by polysomnography, whether they had symptoms or not. It's almost like you don't even need to do the test. So this magic pill It treats sleep apnea, improves mobility, decreases pain, and improves quality of life. That's a pretty good therapeutic profile, and there's no one diabetes drug that's going to do this for you. But this is the therapeutic profile of weight loss in type 2 diabetes, and we know this from the Look Ahead study and the phase 3 clinical trials for obesity medicine. So the Look Ahead study, here's the weight loss curves over 4 years. On top, the standard diabetes support and education. In red, the intensive lifestyle intervention. So you see good weight loss at 1 year, kind of creeping back up to about 4.7% decrease from baseline at year 4. And here's the response for metabolic parameters as a function of categorical weight loss along the horizontal axis here from weight gain of 2%, progressing to a weight loss of 15% or greater. And you can see you really need more than 5% weight loss to make a difference with many of these parameters. But if you look at hemoglobin A1C and fasting glucose on the top, the more weight loss, the better. Same with diastolic and systolic blood pressure in the middle, and the increase in HDL, decrease in triglycerides as well. So in diabetes, the more weight loss, the better, above 5%, up into and including 15% or greater. And some speakers have mentioned this DIRECT trial from Northern England, Roy Taylor and his group. I think this is a really amazing study where he took general practice clinical venues in the north of England. Half of them saw diabetics with standard of care in the UK. The other half, patients were taken off their diabetes medicines and put on a very low-calorie diet for 3 months, and then gradually regular food was introduced up to a 1-year follow-up. The lifestyle intervention, the very low-calorie diet, was conducted by nurses and dietitians that were already in these clinics. So this is kind of a real-world study. The intervention group did lose 10 kilograms at 1 year compared to 1 kilogram in control. But the intervention group also had about a 0.9% hemoglobin A1C unit decrease, concomitant with the decrease numbers of diabetes medications, decrease in blood pressure medications, decrease in triglycerides, and increased quality of life. But here's the data I think are most remarkable. If you look on the top right, 46% of those patients treated with the very low-calorie diet were in remission after 1 year. No diabetes medicines, normal glucose levels. You don't need bariatric surgery to put diabetes into remission, okay? And on the bottom, you see patients achieving remission as a function of categorical weight loss. When you lose 15% or greater, 86% of those patients were in remission. So I think this study really attests to the power of weight loss therapy in diabetes. And in terms of weight loss medications in patients with diabetes, all of the medications currently approved for chronic management obesity have been tested for safety and efficacy in type 2 diabetes. Here's an example of phentermine topiramate extended release, a trial that I was fortunate enough to be involved in. You see the decrease in weight with placebo versus drug. The decrease in hemoglobin A1C on the bottom there came down pretty well with the lifestyle placebo, but a significantly greater decrease, 1.6% decline in hemoglobin A1C when you combine lifestyle plus weight loss medication. But on the far right, you see that better glycemic control in patients treated with drug more frequently needed a decrease in diabetes medications and less frequently needed an increase in diabetes medications as these patients were actively treated to a hemoglobin A1C 7% target. You also see in the middle there greater numbers of patients achieving hemoglobin A1C targets of 7%, 6.5%. So better glycemic control with less need for diabetes medications. Same thing seen in a study with high-dose liraglutide, 3 milligrams in diabetes. The diabetes dose of 1.8 was included in the study as well as the 3 milligram dose for weight loss. So you can see a placebo lifestyle, liraglutide 1.8, liraglutide 3, decrease in body weight, highest with liraglutide 3. The decrease in hemoglobin A1C was also greater with liraglutide 3 milligrams. But if you look on the right, the percent patients requiring a decrease in diabetes medicines was the highest with liraglutide 3 milligrams, and those requiring an increase were very much reduced in the liraglutide 3 milligrams group. So again, better glycemic control with weight loss with less need for diabetes medications. And consequently, when you look at the ACE algorithm for with hierarchies of preferred diabetes drugs, again, you see this yellow bar at the top, lifestyle therapy, including medicine-assisted weight loss, appropriate for all stages of diabetes. I might just add, as being a member of the writing team for these guidelines, that ACE was we're recommending GLP-1 receptor agonists and SGLT2 as the immediate follow-up drugs to metformin years before ADA and the ACC. So I just wanted to add that to Dr. Chawla's presentation. Thank you, Dr. Chawla. Now, you know, we do have diabetes drugs, though, that are associated with weight loss, and we've seen that through the meetings. Here's a number of trials with various GLP-1 receptor agonists looking at weight loss, monotherapy on the far left. Pretty modest weight loss, 2 to 3%. A little bit more when added onto metformin, somewhat less when added onto sulfonylureas. Same with SGLT2 inhibitors. With monotherapy, fairly modest, 2.5 to 3.5% weight loss. A little more when added onto metformin, less when added onto insulin or oral agents. So we're not getting the same degree of weight loss as if you used medicines approved for weight loss. You know, I think we are seeing more effective GLP-1 receptor agonists being introduced into the market that produce a little bit more weight loss. Here's a study comparing semaglutide 1 milligram a week with exenatide, and we see greater weight loss with the semaglutide, a decrease of kilograms 96 to about 91 or 90, well, it's 5.6% decrease in body weight. So I think this is where we are right now when we look at the weight loss with all of these tools that we have. We see lifestyle 2 to 7%, diabetes medicines about 2 to 5%, obesity medicines 4 to 12% weight loss. Still, there's a gap from these medical approaches to lap band and bariatric surgery. So what's the future hold? One possibility is that the diabetes medicines become more effective for weight loss, perhaps even better GLP-1 receptor agonists than semaglutide. And the obesity medicines are trying to catch up. And the weight loss that we see with medicines primarily designed to increase insulin secretion or enhance insulin action produces as much weight loss as the obesity medicines. If that's the future, then there's a convergence, and type 2 diabetes medicines equal obesity medicines for treatment. So that's one possibility, and that's certainly possible. This is some phase 2 data recently published from Lilly looking at experimental GIP GLP-1 agonist dual functional protein. On the left, you see the maximal treatment dose decreasing hemoglobin A1C by 2.5% units, accompanied by an 11.3% weight loss. On the other hand, the future could go as follows, that yes, there's diabetes medicines developed that might produce more weight loss, but more and better obesity medicines are produced that are may increase weight loss to the point where we close the gap with surgical approaches. In that case, weight loss becomes the primary therapeutic goal with glycemic benefits. And that's certainly possible too. Here we're looking at phase 2 data with higher doses of semaglutide, not 1 milligram a week, but the equivalent of 2.4 milligram a week. And you can see the maximal treatment dose produces a decrease in body weight of 16.3% here. A drug, and this is being, clinical trials are ongoing, phase 3 for an obesity weight loss indication. And there's, as I indicated yesterday, there's, or maybe it was 2 days ago, we've got a lot of drugs in development here for obesity. In red, drugs that act on the brain. In blue, kind of mimics of satiety hormones. In green, drugs that kind of enhance metabolism. I can tell you that there's unpublished data with some of these peptides that also produce 15% weight loss. So you can see if you start combining some of these, maybe the semaglutide with one of these others, each producing 15% weight loss in combination, I'm very optimistic that we will begin closing the gap with bariatric surgery. So last slide here, if we want to practice scientific medicine, evidence-based medicine, if you want to help patients with diabetes and overweight or obesity, get serious about weight loss therapy. Thank you very much.